พูดเสร็จแล้วเอานี้ไมค์ให้อาจารย์มา
แล้วก็อาจารย์มาร์คขึ้นไปข้างบนอ้าวอาจารย์อยู่ข้างล่างอ๋อนั่งอยากเดินอันนี้ของอาจารย์บานใช่ปะไว้ตรงนี้นะนั้นอันนี้อาจารย์ของอาจารย์ปรับไปแล้วปะโอ้โหต้อง
ค่ะสวัสดีผู้เข้าร่วมอบรมทุกท่านนะคะขอต้อนรับทุกท่านนะคะเข้าสู่โครงการพัฒนาความรู้ความเข้าใจด้านเวชศาสตร์เขตเมืองประจำปี 2566 ค่ะและขออนุญาตเข้าสู่พิธีการเปิดโครงการเลยนะคะอันดับแรกค่ะขอเรียนเชิญผู้ช่วยศาสตราจารย์วิโรจน์รักษากุลรองคณบดีคณะแพทยศาสตร์วชิรพยาบาลเป็นผู้กล่าวรายงานในพิธีค่ะขอเรียนเชิญค่ะ
Dean of the Faculty of Medicine, Washira Hospital, the Executives of the Faculty of Medicine, Washira Hospital, and all participants. As the chairman of the project committee, I feel really pleased and honored in having the presence of Assistant Professor Chakravut Manirith, Dean of the Faculty of Medicine, Washira Hospital, who provide over the opening ceremony of Urban Health Knowledge Developmental Project for the Faculty of Medicine today. In the year 2023, the Faculty of Medicine Washira Hospital has implemented the Urban Health Knowledge Developmental Project for academic and professional staff. The objectives are to provide the concept for faculty staff to understand the urban medicine, to promote the knowledge and the skill to be a core competency of academic staff and professional supporting team. And at last, to transfer the knowledge of urban health to achieve our organization mission to be a leader in urban science. In this connection, on behalf of the project working committee, I would like to convey our sincere appreciation to lecturer and all involved people for their kind contribution and cooperation given to this project. May I now invite Assistant Professor Chakravut Manirit, Dean of Faculty of Medicine, Washira Hospital, to give a speech on the opening of Urban Health Knowledge Developmental Project. Thank you.
Deputy Deans and Assistant Deans of Faculty of Medicine, Washira Hospital, Professor Dr. Mark Gregory Robson, participants and project working group. It is my great pleasure and honor to preside over the opening ceremony of Urban Health Knowledge Development Project 2023, which aims to broaden profile understanding on urban health for the faculty, personnel, both academic and professional support staff. The Urban Health Knowledge Development Project 2023, which I believe that it will be a significant lecture because we have invited distinguished guest speaker from abroad to share his expertise with us. Thus, I would like to take this opportunity to welcome Professor Dr. Mark Gregory Robson, Department of Plant Biology, Roger, the State University of New Jersey, USA, who will give a lecture on the topic Challenges and Opportunity in Global Health. I do hope that the knowledge receiving from outstanding international experts today will be beneficial to our participants, that they can utilize it to improve their concepts and skills, to work with multidisciplinary team, as well as disseminate knowledge to other involved parties for better understanding on urban health issues in order to help driving our university mission to achieve our goal of being a leader in urban health. May I now declare this academic event open and invite Professor Dr. Mark Gregory Robson to deliver a lecture. Thank you.
So good afternoon. My Dayan. Good afternoon. Dimat Kap. So I'm so happy to be here. I'm so proud to be here, and I feel very privileged to join you today in this beautiful building and just to spend a little time with you and talk to you a little bit about this topic. So I'll tell you a little bit about me first, and then we'll talk about science and we'll talk about what we might do together. So I have had the privilege of coming to Thailand for about 30 years, but my Thai language skills still terrible. You know, when people say, Ajahn, my Thai Thai, and you go, Nit noi. So I've been trying very hard for 30 years, but it's very hard for Farang to speak Thai. Oh, you want, we can take it at the end. Oh, we take, okay, Thai lop, Thai lop, Thai lop, all right. Really like Thai people, Thai lop. So now we have the most important thing, we have the photo. So people know that we came and we got together. So when I was in graduate school, before most of you were born, I had a classmate from Thailand. He was a Fulbright scholar from Songkhla, Ajahn Praser Chittapong. And Dr. Chittapong eventually became the president of PSU. Those of you from the South know in Hachai, it's Prince of Songkhla. And after he finished being the president, he was elected to parliament. But we know, and so he, no parliament, then they have a new election, he get elected again. And so I have had the privilege of coming to Thailand for a long time, thanks to Dr. Prasert. And then a few years ago, we had NIH, National Institute of Health grant at Chula for what we call international training in environmental and occupational health. When that finished, we had a project with Mahidol on geohealth. So I've had the privilege to come to Thailand many times and to appreciate the exceptionally wonderful healthcare system that you all represent, that some of you as training and some of you as very senior. And I think you should be very proud as a Thai person for the excellent healthcare program that you provide for the 70 million people in the Kingdom of Thailand. You know, people, when they study health systems, actually study the Thai system around the globe, you know, because you've had universal health care for a long time, something we haven't been able to have in the US yet because of the politics. So today we're going to talk about, because this is an urban health conference, but my instructions were to talk about challenges and opportunities. I'm going to drive you crazy walking around, aren't I? That's okay. I like to move around. We're going to talk about challenges and opportunities in global health and how it relates to your building an urban health program. And I'm so excited for you, so I'm going to volunteer to our many deans and colleagues. I volunteer to you that I will be happy to be volunteer faculty to help you with this. I come from New Jersey. New Jersey is a small state in the northeastern part of the US. It's the most urban, densely populated state of all our 50 states. We have 9 million people in one small place. So it's like Bangkok traffic Friday afternoon, same. So I appreciate what you plan to do and how exciting it is. To my knowledge, the other programs don't have this urban emphasis yet. So you get to be first, Nung. And that's really exciting. So congratulations to the leadership here in the university, at the hospital, to take this bold step. So I'm really pleased that you're doing that. All right, so what are we going to do? We're going to say, oh, wow, what a nice poster. We're going to talk about where are these opportunities for global environmental research as they relate to urban things. What are the challenges? What are the challenges? There's always opportunities, but there are challenges, okay? I'm going to give you some examples from some work I've done here in Thailand, and probably some of it you know very well and some surprise to you, and then talk about some in other places too. And then we're going to maybe look at the bright side. You have to sort of smile. When you're in health science like we are, you always have to be optimism, right? You have to be optimistic, and you have to always try to smile. I think the world learned for 3 years how important all of what people do in health science, but especially all of you who deliver health science, nurses, physicians, and other people in immediate care, most important people in the whole world. And people maybe didn't understand that before, but they understand it now, okay? So we're going to talk about that. Now, part of the challenge is the world's getting to be a busy place, okay? When you woke up this morning, there were 250,000 people on the planet that weren't here yesterday. And tomorrow when you wake up, 250,000 more people that weren't here today, okay? So right now we have 8 billion people on the planet. By the time that many of you are my age, there'll be 10 billion people. It's going to be your problem. Won't be my problem. I will be very dead, okay? Long gone. but you will be the people to deal with that challenge. Every day about 360,000 babies are born, but some people leave. So the net is about 250,000 people, okay? So, but you can see where the people are going to live. They're going to live in the developing world. Now you say, so where is the Kingdom of Thailand? So right now, Kingdom of Thailand is still listed as developing. It's obviously the hottest economy in Southeast Asia right now, okay? And certainly if you are driving in Bangkok traffic or trying to get on the BTS in the morning like I do, I'm here for a month this time, you say, well, we're a very developed country. I'm sorry, Ajahn, why you say developing? But if you look at, the rural components in the kingdom, it's still listed as developing, but very quickly, obviously. So that's a big responsibility. Thailand has to be one of the leaders here in Southeast Asia region because of that, and you are representing that with your urban health initiative. And when you think about it, the world was kind of slow, even to like 1950s. Not a big, look, boom, it just jumped. Okay, and that puts challenge. Yeah. Oh, we need two of them. Okay, we can do that. Oh, just one. Are you sure? This one is better. Okay. I thought maybe. All right. So, oh wow, much fancier. All right. So, we see this big jump in population, and we know that more and more people in the same space, many places that are rural are going to become urban. Okay? Look how big Bangkok is now. So for the older Ajahns here, and for me as Farang, but coming for 30 years, I still have project in Rangsit. Some of you know where Rangsit is. And we used to leave Bangkok, and then you drive for 30 minutes, it's rice paddy, and then now, just Bangkok. Bangkok doesn't stop. All the way to Rangsit now is Bangkok. So Thailand has become such an urbanized place. All right, so what comes with urbanization? What comes with this globalization? The first thing, of course, is feeding people. Okay. Now, since many of you are directly involved in family medicine, primary care, skilled nursing, you have to have healthy mom and then good place for delivery for healthy baby. And we all know when we study this that if baby is born healthy and the baby makes the first 12 months, it's a good sign, right? When do we measure things? We measure things in public health, mortality at birth, mortality 1 year, mortality 5 years. You get past 5 years, you can live to be old person like Ajahn, okay? You can be old, 69, all right? But where are people needing food? And you see, there are some people that need a little bit here in Thailand, but Thailand in good shape, okay? But look at Africa. Africa is where the fastest growing population is. And you say, well, this is Thailand. But no, Thailand has, like the US has, like Poland, like Germany, like France, has an investment in what's going to happen here, because this is where most of the people are going to be. So I have a project in Niger. Niger is a small country that sits on top of Nigeria. Niger, 40 million citizens. Nigeria is soon going to be the third most populated country in the world. Right now it's China, India, United States, and then Indonesia. In 10 years, India, China, Nigeria, Indonesia, maybe US number 6. So the dynamics of population are changing. In Niger, the average age of the citizen is 15, highest birth rate in the world. The life expectancy is 35, so Ajahn been dead 2 times. It's very, very different for us to think about that. Think about rural people in Thailand and the birth rate. For a long time, rural birth rate in Thailand, 5 kids per family. Now, 2.3, much lower, okay? Rice farmers don't have lots of kids anymore. Same thing in the United States, okay? And because Thailand is becoming more urban with even the rural people. So one of the challenges, of course, is How do you feed folks? This is a challenge that you are just beginning to have. We have very serious problem in the U.S. When we think about poverty in most of the developing world, African countries, South American countries, we think about this kind of picture. This is a political cartoon, obviously. When we think about it in America, we think about people, pumpui, okay? 39% of U.S. people clinically obese. 52% of U.S. people are listed as overweight, okay? It's pretty serious. Now, let's talk about here. 11.9% Thai people are clinically obese, okay? Thai government has recognized that. What changed in Thailand? Thai people decide they like American-style food, okay? McDonald's is next to Burger King, is next to Kentucky Fried Chicken, is by Krispy Kreme donut, okay? You guys like what we eat. It's killing us, now it's killing you. You have to pay attention to that. When I first started to teach at Chula 20 years ago, I went to the first Starbucks in MBK. One Starbucks. Everybody there looked like me, no Thai people. Yesterday I was there, big queue, only Farang. Everybody else, you guys, okay? You have decided you love Starbucks. By the way, Starbucks is 2 times more money in Thailand than US. I don't buy Starbucks, I go to 7-Eleven. Good coffee, 30 baht, okay? Big, no queue. All right, this is what happens. So you say, well, what is that about? Urban centers, there's food, there are hungry people. This boy is actually in the car, he's hungry. Okay, he is. He's eating empty, bad calories. So we got to change that. When I first started teaching, we always talked about these maybe close to a billion, like 800 million. Interesting to see what COVID will change with the real numbers. But 850 million, 900 million people undernourished. Now we have 1.9 billion people that are overnourished. That's an urban health problem because it's poor nutrition, okay? People, used to just cook every day. Think about your parents, think about your grandparents. They have fresh from their farm or they go to the market, they cook. Now people use fast food all the time, okay? And so nothing wrong with fast food, but of course, highly processed, full of salt, all right? So that's a challenge for us. The other thing that happens when we think about an urban health program is climate change. Climate change, Thailand, this week, right? 100 degrees Fahrenheit. I always have a hard time trying to do the Celsius part, because Farang, we use Fahrenheit. But urban spaces, very hot, heat stroke, okay? Water deficit, sea level rise. Think about sea level rise for a country like Thailand with such an enormous coast, okay? That's an enormous risk for you. If you go down in the south, overfishing, okay? Fish species becoming more scarce. Now, places where it's going to be the most serious, oh look, Thailand, okay? Worldwide impact as we go to 2050, not too far away, okay? Certainly crop production going to decline in places like Africa with the most people, but here in a place like Southeast Asia, we're going to see climate change impacts. So how do we do this? How do we move ahead to make people healthy, to improve the life expectancy, to improve the quality of life, and still pay for it? It's going to be expensive. Well, you and I know as health scientists, we do research, okay? That's our, as we say in English, our bread and butter. But everyone that's working in here works as part of a team. All the wonderful nurses that are here, you work very hard alone with the patient, but if you got a problem, you work as a team. If you have to reduce the infection rate in the hospital, you work as a team. If you have to do a teaching program for people to have health promotion, you work as a team. When the physician does surgery, he and she works as a team. So research is a team sport. This is an interesting picture. This is cotton farming in China. So Thailand decided they didn't really want to embrace the idea of genetically modified crop, GMO. Thai people, Thai government said, no, 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 no. China people said, yeah, bring it on. And the Chinese scientists and the Chinese farmers are big adapters of genetically modified crop because they reduce the pesticide input and reduce the poisoning of Chinese farmers. So this is cotton. Cotton is a big crop for China. US used to be a big cotton producer, now we get it from China. And so we're looking at the cotton crop here with the farmer and the university faculty. Used to be about, now there's about 1 billion people that work in agriculture, okay? That's about half of what it was from 1991. Some of you weren't born in 1991, but that's what half it was. To feed people, this, by the way, picture from Chiang Mai, and this is a picture from China. But, it's labor, it's very much human labor, it's occupational health issues, okay? We have to protect our workers, and we're gonna see in a minute that when we had chemical inputs, we didn't do a good job. So think about how we tried to improve food production here in the kingdom. In the 1990s, the policy was we're going to provide Thai rice farmers. You know that half the people in the world have rice every day? Did you know that? That's amazing. So, I'm Farang, I love rice. So maybe once a week, okay? When I was a graduate student with no money, many times, but now old person once a week. But do you know of the 8 billion people in the world, 4 billion people have rice every day for all or a very significant part of their calories, for their energy. So rice production's important. So the Thai government said, okay, we're gonna go ahead and increase rice production. We're gonna increase input of pesticides. And look what, from 1994 to 2005, this data comes from Ministry of Agriculture, Ministry of Public Health, they did that. And when you first look at this picture is from Rangsit, by the way, you see the Thai farmer apply the pesticide, and when you first look at it, you say it almost looks like beautiful dance through the rice paddy. But then you stop and look at it more carefully, and you say, wow, this is an organophosphate insecticide. This is a neurotoxin. This is very potent. And you say to the farmer, I have to use graduate student to say to the farmer, so Chisada or somebody else say to the farmer, do you know what you're doing? And the farmer go, oh, this is going to kill the rice weevil. Well, it's going to kill you too. So that was a challenge. So the Ministry of Public Health, through the Bureau of Epidemiology, started to look at reported pesticide poisoning. This is Thai data, put it in English so I can use it, because I have trouble reading the Thai. But you can see, when the policy first, people had high poison levels. What group of kids were poisoned? Well, the kids 0 to 4. Now you say, okay, from 5 to about 15, not poisoned. Protective factor. What was the protective factor? Why do kids 5 to 15 have low pesticide poisoning in rural areas? This is where I ask question, you give answer. Why do we have lower levels of poisoning in kids 5 to 15? My Diane. Well, where are you when you are 5 years old? School, yeah. School is protective factor, okay? Now, the boy or the girl turns 15, and this is rural people, not people in the city here. They go out and start to work. Look, the rate goes up, okay? Now, this was interesting. So the ministry was taking data, and there was a trend not good, okay? You guys are health scientists. You look for trends. You like to see trends where, infection rates go down, positive birth outcomes go up, obesity rate goes down. This is pesticide poisoning rate keeps going up. So somebody somewhere said, maybe we won't collect the data. And then new government collect the data. You see the trend still goes. You need data to drive the system. And part of it is education, isn't it? You say to people, what is PPE? Before, I like to say, before COVID, the newscaster could not spell PPE, right? Now everybody on the news, whether you watch news in Europe or in Asia or in the United States, everybody, PPE. You know, we all learned about a mask. We all learned about, you know, gloves. COVID taught us many things, okay? And so we asked the farmer, this is the English translation of the survey, what kind of PPE do you use? Number one answer, none. Soon, zero. By the way, same answer in US, not unique to Thai farmer. Okay, but you can see this farmer is spraying pesticide. He has on all cotton, okay? So he thinks it's protecting him. No, right? When you go in to see a patient, what do you do now? You put on a mask, you have on gloves, maybe you put on eye protection. New world for us. The farmer, no, he's got cotton shirt, cotton hat. The English translation come back from the Thai, knitting faces hat. You know, in the U.S. that would be for cold weather, but here in Thailand we don't have cold weather. This is not protecting, okay? So how do you make this work for rural health, for peri-urban health, and for urban health? You have to educate people. But what's the most important thing that you do when you educate people? You educate people at their level so that they understand, right? You know, you are physicians and nurses and PAs and nurse practitioners. You have lots of expertise and lots of training, and that's wonderful. So we can talk as a community because we have something in common. But when we walk outside, you know, we walk through the lobby and to see the patients, you know, that's a different group of people. They don't have our training. You have to teach them the way they understand. So these are farmers, and we worked in rural health clinics, okay? And we brought them in for 1 week training and talked to them and said, make us a diagram of your farm. Show us where the well is. Show us your house. This guy claimed he had elephant. Oh, Ajahn, I have Chan. I said, you have elephant? I went every day, no elephant. But he drew a picture of an elephant. So say, okay, sabai, sabai. So, you know, you have to make the training for people real. As you develop an urban health program, you have to remember that the people that you are helping don't have the sophisticated, detailed training in medicine and nursing and in science and toxicology that we all are gifted with, all right? And then, of course, you can have, you know, celebration, okay? And I have to show you a picture here. This is before Ajahn lose weight, all right? So, pompoi. Once you have that data, you have to make sure that you understand what the data tells us. We decided to look at the risk for people who were growing rice with all these pesticides. And we learned something really important. We learned that the research question we asked was the wrong research question. The risk was not about the rice spraying, which we thought it was, which I had many Thai students get PhD on. We did lots of research. Wrong. We got the right answer to the wrong question, okay? We found out it was the rural people. You know, rural people, they grow rice, but they also grow vegetables. They also fish. Fish was the bigger risk. So we had to see the farmer say, how do they fish? We didn't have any data. You know, you have to observe people. When the first thing that you ask for the nurses, the first thing you ask when you meet the patient is, tell me what you do. How do you feel? You know, what medication do you take? You have to learn about that. You just can't look at the person and make a decision because you don't know them. You have many questions to ask. We looked at these farmers and we said, okay, rice, you know, how much rice do you have? And what do you spray? Or write everything down. And the issues weren't the same. We realized it was the fishing. So we had to watch people fish. We had to ask people how much they ate. Now, you know, one of the big challenges is that people don't accurately know what they eat, including me, okay? When I finally went on big diet, I realized that I didn't have good data. So what we did is we had 54 families that we asked them every day for 2 weeks to tell us what they ate, and they measured it for us. You know, they're farm people, so it's rice and fish and vegetable and rice and fish and vegetable. Pretty uniform diet. But we asked them how much they ate, and then we measured how much they ate, and the error was 300%, you know? So one of my favorite things, I think it's Thai people's favorite thing, but especially for Farang, is, sticky rice and mango, right? Aroy mak mak. And so, say, how big is the portion? And you say, oh, no, it's not big. So if you count the calories, when we asked the people what we thought they ate, and then we actually measured it, 300% mistake. So I went back to my nutrition department at Rutgers, where I work, and said to them, when you do diet studies, how accurate? And they said, oh, it's off by about 300%. Oh, same for our study. So people don't know what they're eating. When you work with people to conquer this newly emerging challenge in Thailand for obesity, you got to help them understand what they really eat and tell the truth, As my mother would say, just don't put one foot on the scale. You have to stand on the scale with both feet. You have to accurately measure the calories. But it was amazing to me that the rural Thai farmer, 300% error, and equally amazing to me that my colleagues who do this in our nutrition department said, oh yeah, that's what we see too, okay? We have to remember who is the most vulnerable in the population. Now with COVID, we learned something very interesting, and I probably paid more attention to it than anybody else in the room, because I'm thinking I'm the oldest person in the room, which is a good thing. I got this far. It's a bad thing. I'll be the first to leave, okay? So when COVID came along, what was the challenge? It was older people, and then comorbidities, right? Obesity, type 2 diabetes, respiratory problem, certainly people that smoke. But most of the time, when we think about who's at risk, we think about it with children. So we did this little study down in the South, and we looked at kids. And we looked at these kids that were between 0 and 5. And, we went ahead and we used the biomarkers. As you know, because many of you have to draw blood, people do not like to give you blood sample, okay? They'll pee for you. You get urine sample pretty easy, but not blood sample. Now, when we do biomarkers, we can measure in urine, in blood, in hair. A little problem for me in hair. But you all have hair. You can measure in hair. You can measure fat cores. You can do fat core. But we decided to do urine. And this is kind of an interesting little study, just a small study. This was Pechite. She's now at Ubon Ratchathani as chair of the Department of Biological Science in Ubon. But, light gray bars are farm kids. Dark gray bars are kids who aren't part of the farm. During dry season, and these are metabolites from the pesticide in kids' urines, the light gray bar is much higher. During rainy season, the metabolites were the same. What does this tell us? This tells us these little kids are getting exposed to pesticides. You have to have an intervention and prevention program, okay? And what do you do when you get good knowledge? You know this as people who are in health science, as doctors, as nurse practitioners. You have to take the data that the researchers do and put it in practice to make a difference, okay? It's nice to publish a paper, but if you publish a paper and you don't act on it, then you truly are just an academic person. You need to do more. So we tried to come up with this model approach to reduce pesticide exposure here in the Kingdom of Thailand. Then we tried to take the show on the road and took it up in the north. Some of you travel to the north sometimes. Very different kind of farming. You need to know what's going on. The north is rapidly starting to develop too. We think of Bangkok as the only big city in Thailand, and then the other cities are obviously smaller. But now even a place like Songkhla has, way over 1 million people. But this is up in the north. And what we looked at up in the north was how to intervene with maize farmers. And when you develop interventions, they have to be practical. I gave a talk, and some of you are recent physicians, so you will appreciate this. I gave a talk to our family medicine residents. And I'm talking, and there was a young man who, he raised his hand, and he was, very impressed with himself. He goes, Dr. Robson, I think you've missed the point. I said, yearly, you do? Okay, doctor, how have I missed the point? All you have to do is put people in Tyvek suit. You don't need all this knowledge, attitude, and practice. Put them in a Tyvek suit. I said, doctor, have you ever worn a Tyvek suit? Well, no. I said, I see. I said, how long do you, so I kind of ignored him. He needed to, as we say in English, be taught a lesson. So I said to the other people in the room, how long would he last in a hot temperature in a Tyvek suit? And one of the young men there was an industrial hygienist on the team. He goes, 25 minutes. I thought he might have said an hour, but 25. You know, you have to have the right intervention. And plus, for rural people, they can't afford Tyvek suit, right? Look how much it cost the hospital here during COVID for Tyvek suit. And you're the health scientists, you're the health providers. So you have to make sure the intervention makes sense. So we found out that a decent mask, N95, and some goggles and gloves, we could reduce the risk enough for the pesticides. But the thing that worked the best was poster in each home. And people were proud to accept the poster. The Thai graduate student, Den Peng, put the poster in each home, and that was the way that we intervened, okay? And work with the community leaders to talk about how important this is. That's part of this intervention. That's part of the challenge. After you do it a while, you can start to write policy papers that hopefully government people will pay attention to. Because, you know, one of the things, there's an expression in English that I disagree with, you know, and they say, money can't buy you happiness. Oh, yes, it can. You know, there's that song, money can't buy you love. I don't know about that part. But as a researcher, money can buy me a lot of happiness. Money can buy me students. Money can buy me laboratory equipment, you know? What's the easiest way to solve public health problem? Money. And so, you know, not to be, sort of sarcastic, but to be honest, you need resources. How do you, resources, you explain to the people who are making the decisions that you need more resources. And so you write policy papers. One of the most important things that you need to understand is something that hard for me to learn as an old person, and many of you are very early in your career, so I will give you fatherly advice, maybe even grandfatherly advice, is something that I learned the hard way, is the humility to learn. Now, you look at this picture, and some of you are physicians who have had some occupational experience. You look at this and you say, well, what is this? So this is rural people with arsenic poisoning. When we first saw the skin lesions, when they progressed, we thought, oh, what? They invited me to go, oh, John, what pesticide is this? I'm thinking real hard, no pesticide. After like a year, we learned, you know, there's just like many researchers already know in the South, it's arsenic poisoning. Hypopigmentation, palmar-planar keratotic lesions. These keratoses are very typical arsenic, and then full cancer lesion. It's arsenic, okay? In this village, okay, so this is, each dot is residence and village. The red dot goes up to 200 ppb to 1,000 ppb, okay? In some parts of the subdistrict, they had 25% people had that kind of lesion, and many of them died, okay? The WHO standard is 10 ppb, and these people had 1,000 ppb, okay? How do you fix that? Intervention. This is one that Thai government collaborated with Japanese government and used pipe water, okay? New deep wells, shallow wells. You know, arsenic has no taste, no smell. You and I don't know if we're being exposed to arsenic. The water tasted fine. And you're a rural person, you can dig a well with a shovel by yourself. Start today, it's almost 1:15. We're almost done the lecture, by the way. Dig a well fast, and tomorrow you have a nice looking water, but full of arsenic. So we had to learn to come up with an intervention that was expensive, and then take that data and try to make a model to predict where the problems would be with colleagues from both Chula and several other places here in Thailand, and build models. So it's all important. You gotta know the people you serve, okay? They may be farmers, but they may make incense sticks too, okay? The dust in the incense sticks was, these farmers had high rates of respiratory problems and very low peak flow. You know, when you do the peak flow, this young boy, 18, beautiful young man, very strong, peak flow like 85-year-old grandfather. Why? Because dust all over his workplace. In addition to growing rice and vegetables, he made incense sticks, okay? And finally, we have to, as we finish, we go back to where we started about eating. So, you know, there's many challenges. There's air pollution problems in Bangkok, air pollution problems in New York where I live. There's traffic problems in Bangkok and Beijing and Bombay and New York and Los Angeles. You find a big urban area and there's lots of traffic. And yes, someday we'll all have electric cars. I won't, I'll be dead. Some of you will have electric cars, but that's not happening next week. So next week you have to think about choices. But most of the time, the low-hanging fruit are things like malnutrition. Do you know that we have 3 million kids in the world that die every year from malnutrition? I thought these little kids were so cute. They were part of a study we did. It's the food system. How do you distribute food? This is Vietnamese picture, floating market where the lady distributes food. You know, we have floating market here too. Floating market here is more of a tourist thing, but in Vietnam, it's actually how groceries get delivered. The diet is good, but the food is only lasts a short time, okay? During COVID, we learned about supply chain, and that word was very popular. Oh, we can't get this, we have supply chain problem. This is supply chain in Burma, Myanmar, okay? This is farmer growing groundnuts or peanuts. This is the supply chain, manually sorting the peanuts. It's not sophisticated. It's not a big truck trying to cross a border. It's human capital, okay? And finally, when we think about all these challenges we have to remember something very important, and Thai people know this very well, that sometimes all the planning, all the research doesn't prepare us for things like the tsunami of 2004. I was here doing Fulbright down in the south at Songkhla when the tsunami hit. Nobody could see that, okay? It challenged the healthcare system. It taught us that we don't always know what's going to come next, okay? Very, very sobering experience. This is one of the students from Chula Virus. He now works for Siam Cement. And I finally was able to reach him, and he explained to me what he was doing. And I was so sad when I saw this, but then I realized that people are resilient. You know that. You've come through so much in the last 3 years as healthcare workers, as the people in the front of this problem, the people who solve the problem. People are resilient. In December, looking at the tsunami stuff, I was just depressed, but I was wrong. I went, and this farmer, so this is a little mobile clinic, and I asked, these are Thai medical students from PSU. I said to my translator, I said, he looks okay, what's the matter with him? I said, oh, John, he's fine. He lives up in the mountain, the tsunami didn't affect him. He had his water buffalo step on his arm in 1979. And in 2004, the doctor was first time the doctor came. So he showed his arm to the doctor. Doctor said, it looks good. Okay. So what does that story talk about? It talks about having the availability, access to health care, okay? His concern, now think about it, you know, sometimes you have people that complain they have to wait 2 hours. He waited 25 years to show his arm to the doctor. Lucky for him, his arm was okay. But people are resilient. People will collaborate, okay? These are young Thai pharmacy students working with pharmacists from the Netherlands, okay? Sometimes it doesn't go well. Your neighbors in Indonesia, okay, this is Banda Aceh in Indonesia and Sumatra. So Thai people lose about 5,000 citizens and tourists during the tsunami. Here in Banda Aceh, 250,000 people in 15 seconds. And it behaved differently. The water came in much further in. The only thing that was left standing in this region, this is the big mosque down there. Everything else flattened. This is very much a Muslim area. And so we went to meet with the residents to see what the challenges were. Again, this is where Ajahn weighed 140 kilos, not 72 kilos. So you can see, not good. But we met with the people, and so we said to them, are you worried about sanitation? Are you worried about water? And the mother said, no, we don't care about that. We want to know what our kids are doing at night. We want to know why they don't stay in school. You have to understand what the people's concerns are, not your own. We went back to teaching basic nutrition, and I was all excited about putting a better water system. Nobody cared about that. So, the future for this is the way that you deliver education here in the hospital. The future for you is the very bold and progressive approach that you are taking here, for which I am so impressed and so pleased to know that you're going to concentrate on urban health. So the last 3 comments, and then we take a couple questions, then you can listen to something more interesting than me. So what are the 4 pillars of urban health? The first one is legacy from industrial. Yes, everywhere you look in Bangkok, there is construction, right? 24 hours a day, the workers are building buildings. I come 3 times a year. I leave, it's a hole in the ground. I come back, in 4 months for another visit, and it's another shopping center, okay? Another Paragon, another Emporium, another Econ Siam, and that's fine. But it's built on what might have been maybe an industrial kind of effort. So you have metals and other contamination. The second part of urban health is the disparity. When you go into Paragon, as an example, what do you see? Cartier, Gucci, Louis Vuitton. You say, wow, this is pretty bougie. But you also walk a couple blocks away and you see plenty of poor people. Okay, that's the same in the US, that's the same everywhere. By the way, shopping tip for all of you. You want to buy Cartier, Gucci, or Louis Vuitton, don't buy it in Bangkok. Come visit me in New York. When my Thai students come, my daughter lives in Manhattan, and the Thai students tell me it's at least half price in New York. Isn't that sad? You can buy it much cheaper, even with the airplane ticket, you buy it in New York. Third part of urban health is trying to have a workforce that meets all the needs. During COVID, we realized there are not enough nurses. There are not enough doctors. Need more. So congratulations to the hospital in training all these folks. And the fourth thing goes back to my little sarcastic comment, but it's true, is you need money. Now, money meaning you need to explain to people, that politicians, that's where the resources should go. Now, if you have ever been, and probably the dean's office leadership has, if you ever go, even within the university, right? You go to see the head of the hospital, and the infectious disease doctors go, we are most important, because if we have an infection, we've lost the hospital. Then the surgeons come and go, we save people's lives. We're the surgeons. And, the nurses go, yeah, but we cover up your mistakes when you do something wrong. Everybody stands in the queue to say, I'm the first, Nung, right? But when you look at it in a more global thing, you have to go and say to people, we don't need another toll road, okay? We certainly don't need more cars here. We need to concentrate on urban health. We don't need to make Bangkok bigger. We need to make it better. We need to make, the urban centers have the access that they need. So congratulations on that important move that you're taking. Thank you for being so patient and staying awake. One of the challenges is, I gave a talk and I saw people were kind of, this is after lunch. This is a very dangerous time of day to talk because, people are full, and then you have on the mask, so not enough oxygen, but nobody fell asleep. Maybe the one boy in the back, but most people stayed awake. So thank you for staying awake. Thank you for the privilege to meet you. Kap kun kap. So we could take 1 or 2 questions or 1 or 2 comments. If you have, I guess I'm going to ask a question first. I'm going to drive this poor man nuts moving around. Next time, if I come back, he's going to chain me. I like to move, you know. In New Jersey, I'm always afraid we get shot, you know. So what do you think is the biggest challenge to build the urban health program? So the vision is here, and it's a wonderful vision. What's the biggest challenge to build an urban health program here at this wonderful medical school in this beautiful hospital? Somebody tell me, what's the biggest challenge you think? Don't be shy. Come on. Well, what's the biggest challenge? What do you think is the most important thing you need to do for an urban health program? What do you think? So I say, oh, now I'm going to make it really difficult. So I say, congratulations. You are in charge of the whole urban health program. Tell me the most important thing you need. And what are you going to tell me? What are you going to say? Go ahead. What's the most important thing you need? Somebody say. He's a young physician. He's going to say money. Watch.
I think it's got to be a good health policy.
Good answer. Okay. And what does a good health policy include? Hard answer.
It's a very tough one.
That's why I'm a John. We get to ask tough questions.
Because it needs to include the benefit of all people in Bangkok or in the city, which is very variety of people. And different sector may be affected by different policy. So to have a really good one would be a really challenging one.
And the most important point that our wonderful young physician made was it affects all sectors. What did we learn from COVID? You know, normally, right, if I were to ask you, and I'm not a physician, I'm a toxicologist, but if I were to, or as my daughter used to say, my father is a pretend doctor, not a real doctor, which I know that. But, you know, if I was to say to you, normally, who's the most at risk? You'd say, oh, John, you know, people that are poor, they don't have a good house, that they don't eat right. But no, when COVID came along, COVID didn't care if you were the wealthiest people in Thailand or the poorest people, did it? COVID just said, you. Okay? So that's why the policy has to affect everybody and has to be equal. You know, COVID became the great equalizer, so does the policy for urban health. So the policy has to come first, doesn't it? So anybody want to make a comment or a question or correction? You can correct too, you know? You know, they always tease about what is definition of expert. Expert is somebody that gives a talk 50 miles from home, okay? If I was closer to home, I would not be expert. I would just be somebody that works at my university. But I'm visiting your university, so I get to be expert. Anybody else have a comment? No? Okay. Well, then as we say, class dismissed. Thank you.
As a representative of the Wachira Hospital, I would like to say thank you to Professor Mark Robson for giving us an educated lecture for today. And I hope in the future we can collaborate even more in the future. Thank you.
Lastly, let me introduce Assistant Professor อาจารย์วิโรจน์รักษากุลนะคะ for the closing speech.
Professor Dr. Mark Gregory Robson and all participants and project working group. On behalf of Faculty of Medicine, Wachira Hospital, Navamintara Thirat, I wish to express our heartfelt thanks and gratitude to Professor Dr. Mark Gregory Robson for accepting to be our guest speaker and giving a valuable lecture for all of the participants today. Throughout the entire lecture, which was very impressive, I believe that the knowledge that we receive from Professor Dr. Mark Gregory Robson will bring about perspective to the personnel. And I hope all of us can be used in our work to improve urban health implementation in Bangkok and Thailand. I also would like to thank you, the executives of Faculty Medicine Washira Hospital, all participants and organizers who are the key part of making success of this project. I hope that we would have the opportunity to welcome you again in the near future. Lastly, please allow me to declare the Urban Health Project Developmental Project closed by thank you our guest speaker again, and may I invite all of you to give Dr. Mark Gregory Robson a big round of applause. Thank you.
And as a gratitude, we have prepared a little gift for our professor here. Can you please to the stage, please? So we can have a gift and we can take a little pictures. Thank you.
ค่ะสำหรับผู้ที่เข้าร่วมอบรมในวันนี้นะคะรบกวนลงทะเบียนออกแล้วก็ทำแบบสำรวจความพึงพอใจนะคะเมื่อลงทะเบียนออกแล้วก็ทำแบบสำรวจแล้วหลังจากนี้ภายใน7วันนะคะจะมีใบ e-certificate ส่งไปให้ท่านทางอีเมลนะคะขอบพระคุณมากค่ะทุกท่านสวัสดีค่ะด้านหน้าห้องก็มีQR code ให้สแกนได้นะคะด้านหน้าก่อนลงลิฟต์นะคะ
ในสเต็ปต่อไปนะครับเราจะมีการทำเป็นซับไตเติลให้เนาะครับแล้วก็สำหรับถ้าเผื่อใครคิดว่าอาจจะอยากกลับไปทบทวนดูอีกครั้งหนึ่งนะครับหรือสำหรับคนที่ยังไม่ได้เข้าเนาะเราก็จะได้เอาไว้ดูในคลาสนี้ได้นะครับครับขอบคุณครับ